Denen, and I am going to be talking about the mental health needs of refugee populations and a specific approach to those mental health needs, which is called trauma-informed care or a trauma-informed approach to serving these populations. I'm going to give you a little bit of an agenda of what I'm hoping to talk about today. If you paid close attention to the agenda that was sent out initially, it is a little bit different. I'm still going to talk about all the same things. I just kind of had to adjust it a little bit for time constraints, but we're going to talk about displacement and the stages of a refugee journey. I know this is probably familiar to some of you, and so I'm not going to spend a whole lot of time on that. And then we're going to talk a lot about that displacement and trauma as something that refugees often experience. We're going to then transition into the health impact of trauma for both children and adults, and then we're going to talk about trauma-informed care. At the end, there will be a Q&A session, but again, like Olivia said, please feel free to drop questions in the chat. You know, I enjoy when people engage kind of like throughout, so no worries if you have questions kind of as we're going through. So first, talking about displacement in the stages of the refugee journey. Displacement is when somebody is being forcibly removed from home due to persecution, conflict, generalized violence, or human rights violations. This is often associated with the pre-flight stage of the refugee journey, because the pre-flight stage is when there is violence, some type of upheaval, something going on in life that is just making staying in their community or in their home unsustainable. The flight part of the refugee journey is then that journey from displacement into resettlement somewhere that is safer. There's a lot that goes on in the flight part of this journey. You know, it could include refugee camps, it could include travel. There's a lot of unknowns, and that in itself can be a very difficult thing for refugees to experience, because there's uncertainty. The children may be removed from the family in some situations, and there's just kind of a feeling of helplessness oftentimes in these refugees. Sometimes, you know, even after they get settled somewhere, but, you know, especially during that time. Resettlement is when they get placed into a safer environment, such as when they come here to the United States and, you know, find a place to live, find jobs, things like that. That is all part of the resettlement process. But this is also challenging because it involves a loss of culture, a loss of language. A lot of people don't have the community that they had in their home of origin. And so it becomes a very challenging experience for these people, because they're stepping into an unknown. They don't know how to communicate. You know, the culture that, in terms of language, they don't know how to communicate. That's something that they have to learn. You know, they don't have this sense of social support that they maybe had before. And it is just a very challenging experience. So any questions about that before I move on? I wanted to be brief there. Okay, so we're going to talk about trauma and displacement, and I'm going to start with the definition of trauma. So trauma results from an event or series of events or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, or spiritual well-being. That's a mouthful, but we're going to break it down into those 3 E's, which are the events, the experience, and the effects. So an event that could lead to trauma is something that is a threat of harm or death, particularly physically or psychologically. This can be natural disasters, it can be violence, it can be things like, you know, car accidents as well. But if we're thinking about the, you know, the refugee experience, it is often a result of some kind of violence or some kind of war that has put them in a place where they have to flee from home. The experience part of it is about the fact that every traumatized or every person who experiences a potential trauma is going to interpret that trauma differently. So two people that are both refugees, even from the same community, are going to have a different experience or a different like interpretation of what's going on there, and that can affect whether the event becomes a trauma that impacts them long term. Oftentimes, though, in the experience of a trauma, there's a power differential. So if you think about, you know, something like domestic violence, there's usually somebody who is doing the abuse and somebody who is the victim of the abuse. And something like war, there is, you know, the government or whatever else is going on there that is creating an unsafe environment. And then the refugees themselves are, you know, at a lower power level than the government is in that situation. Also, I just want to say I'm in my home and my cat just jumped up on the table, so I apologize if he makes an appearance. We'll see what happens. The E for effect is that the effects of trauma can be long-lasting. The symptoms of trauma can occur like immediately, or they can occur slowly. They can be short-lasting or long-lasting. But what we do know, and we'll get into this a little bit later, is that when people experience trauma, even with or without good protective factors, which are things that can like reduce the likelihood of negative consequences, we do often see negative health consequences related to that. This is a definition of displacement, since we kind of defined trauma there. It's being forcibly removed from home due to persecution, conflict, generalized violence, or human rights violations. So really, like, looking back at what this definition of trauma is, and whether, like, the fact that there's an event, you know, the experience associated and the effect of that, if we look at this definition of displacement, like, that in itself, it qualifies as a potential trauma, and it depends on what the individual's experience is with that, and, you know, how they interpret the events that determines whether they have you know, long-lasting effects related to the event. So trauma impacts us in a lot of different ways. It can impact us emotionally, physically, cognitively, behaviorally, and existentially. And we're going to break each of these down because I want to help you all have a good understanding of what trauma is and how it impacts us in different ways. So emotionally, these are some of the immediate emotional reactions you might see. So when somebody first comes to this country, I know a lot of you kind of work right there as people are arriving. You might notice numbness and detachment, anxiety or severe fear. There may be guilt, particularly survivor's guilt, which is an interesting phenomenon where, you know, particularly if it's a loved one that has passed away, or if they witnessed something violent happening to that loved one, there's often this feeling of like, what if I had done something different? What if I could have saved them? And so then there becomes a lot of guilt in the fact that they have survived, and that can impact them emotionally as well. I'm not going to read this whole list to you, but again, these are things that you're going to notice potentially in refugees that have recently arrived. I do want to point out the disorientation piece, because disorientation, as you may know, is this feeling of kind of like being detached, not really knowing what's going on. And I think that's something that is seen a lot at least in the populations we work with at MEDS, where there's just so much going on. There's so many things that they don't know, and it kind of puts them in this like mental place of just struggling to function, because there's so much support that's needed when you are disoriented in that way, when everything's new, when you don't know, you know, you don't always know what's going on. And so if you see people being, you know, numb or acting like they feel numb or kind of being detached. That's a piece of what disorientation might be. Physically, you may notice, or people may report some, nausea or GI distress. They may sweat a lot or shiver. There may be faintness, muscle tremors, or uncontrollable shaking, elevated heartbeat, respiration, blood pressure, extreme fatigue or exhaustion, a greater startle response, or depersonalization. So this is the interesting thing about physical and mental health, is that we often consider them to be two different things, but they actually work very closely together in our bodies. So for example, if you've ever injured yourself in some way, like say you broke an arm, you probably were not the happiest person you've ever been in that situation, because what we experience in our bodies and what we experience mentally coincide. In the same way, if you're somebody who's, really anxious or depressed or something like that, then during that period of time, your body's probably not going to feel as good. You're not going to be as ready to, get up and run a marathon or, things like that. It's important to understand kind of that connection there. Cognitively, so in terms of like thinking and concentrating and things like that, people are going to have difficulty concentrating. They are also likely to have rumination or racing thoughts. They may have a distortion of time and space, and this happens especially related to sleep and jet lag. I mean, that's not the only thing that causes it, but I'm sure if you've ever traveled, out of the country and you kind of had to adjust to a new time zone, you may have experienced this to a degree as well. What happens though is that when there's so much going on, and so many unknowns and so many questions for our refugees that come in, is that exacerbates the problems that we see that any of us would experience at any given time. Because hopefully if you've traveled overseas, or to a different time zone, you also were not being displaced from your home, and you had some ability to communicate, you had resources, finances, whatever. But when you don't have all that, and plus there's that, there's things like jet lag and maybe not sleeping well and being confused and anxious and depressed and worried about your family, that all just kind of exacerbates the problem. Related to that, there can be memory problems, such as not being able to recall important aspects of trauma. This is actually a criteria of post-traumatic stress disorder, is for people to have difficulty recalling certain aspects of their trauma. That doesn't mean that if people have problems that they have PTSD, but it is a common experience for people who have experienced trauma. Oops. Behaviorally, you may see that people startle really easily. They may be restless. There may be changes in sleep and appetite. They may have difficulty expressing themselves, which kind of goes along with that numbness that I mentioned a minute ago. They may be more likely to be argumentative, or on the reverse of that, they may be very withdrawn and have difficulty engaging. And you may also see an increase of alcohol, drugs, and tobacco, often as a way of self-medicating or a way of helping themselves feel more in control of something. I mean, we do that anyway. People do that anyway, where if they're stressed about something, maybe they'll grab a beer or something like that. But when the stress is so intense, you really have to be mindful of people doing that, because you don't want it to become a negative coping mechanism that can lead to further problems down the line. And then existentially, you may see people have kind of like a restoration of their faith or the goodness of others. Like I talked with some refugees that we had at Meds that were like, this is amazing, like God is so good, everybody's been so supportive, and that's wonderful when people have that experience. But there can also be a loss of self-efficacy, which is the feeling that you are capable, essentially. There can be despair about humanity. And there can be immediate disruption of life assumptions such as fairness, safety, goodness, predictability in life. That last bit is, again, very, very common in people who have experienced trauma. So I'm going to transition. If nobody has any questions, and please feel free to let me know if you do. I'm going to transition into the health impact of trauma. And I'm going to start by talking about the health impact of trauma on children. So you may have heard, because it's been a big buzz topic lately, of adverse childhood experiences, which is a way of couching the concept of children experiencing trauma, essentially. There's a lot of things that can go into the adverse childhood experiences, also known as ACEs. But, displacement and being a refugee and, having to resettle in a new place can all qualify as an ACE or a trauma. I would encourage you, if you have time or if you're interested in this, to look up ACEs. There's a lot of really good information. There's some great TED Talks about it, and it can kind of just add to your understanding of trauma and how it helps people. But here's what happens when a child experiences an ACE, or an adverse childhood experience. It actually impacts their neurocognitive development. So it impacts their ability to socialize, to develop emotions in a way that is healthy, and they also experience some cognitive impairment. So a lot of times kids that have experienced significant trauma, they may, for a period of time, fall behind in school or have more difficulty communicating with other people. When this happens, if there's no intervention, or the intervention is limited or whatever, that can lead to an adoption of health risk behaviors, especially as these kids develop into teenagers and they're more at risk of engaging in risky behaviors anyway. So they may be more likely to use drugs, to smoke, to do these things that actually have a very negative impact on your body, and that can then lead to chronic disease. That chronic disease can then continue to impact them. They may not have the resource. I mean, hopefully they have the resources, but realistically, not everybody has the resources to get treatment for what's going on. Or there may be, systems in place that make it really difficult for that to happen. And ultimately that can reduce life expectancy over time. So this I thought was really interesting, and I wanted to share. This is key research about the ACEs. In the US population, people with 4 or more ACEs, which again, if you look up ACEs, you can see kind of what qualifies as an ACE. For the sake of time, I'm not going to belabor that point, but if you have 4 or more ACEs, you are 1.4 times as likely to have diabetes, 2 to 2.3 times as likely to have a stroke, cancer, or heart disease at some point in your life. You're 3 times more likely to smoke cigarettes, which has, negative health impacts. You're 3.2 times as likely to have chronic lower respiratory disease, 5 times more likely to have major depression, and 10 times more likely to experience problematic drug use, and 37.5% as likely to attempt suicide. So trauma is very costly, not only emotionally for those that experience it, but it's also very costly for public health. And it becomes a problem, particularly when people have these risks, and then, the systems in place don't make it easy for them to get the treatment they need. And or the treatment is, very costly either for the patient themselves or for the insurance company, and it just causes a lot of problems down the line. The impact of trauma on adults is similar, but obviously it doesn't start quite in the same way, because hopefully an adult, has developed neurocognitively, and so they're not going to be impacted the same way as a child would be in that sense. But when you experience chronic stress, there's actually damage to your body and brain. And this happens because of the stress hormone, which is called cortisol. And the more cortisol builds up in your body, the more problems it causes. So cortisol or a chronic amount of cortisol in your body is associated with all kinds of health disparities, including, heart, liver, autoimmune, and chronic obstructive pulmonary diseases. Really, like if you look at the ACEs studies, and again, I think within the last few decades, the ACEs thing is pretty new, but you can trace just about every chronic health condition potentially to a trauma. Obviously, not everybody who has a chronic health condition has experienced a trauma, but if somebody has experienced a trauma, you can almost be certain that they will experience some kind of a chronic health issue at some point in life. That chronic stress is also associated with mental health diagnoses. Most commonly, when a trauma has been experienced, that would be the development of post-traumatic stress disorder, or PTSD. You also often see a lot of major depression, anxiety, panic attacks, adjustment disorder, which is just the difficulty kind of navigating a new situation and needing support in doing that, as well as somatization, which is when your mental health difficulties manifest kind of in your body. So that goes back to what I was saying, a few minutes ago about the connection between the body and the brain, or like the physical health issues and the mental health issues, where they very much work together, and that is especially the case with something like trauma. There are protective factors, though. So again, I think I briefly mentioned this at the beginning. A protective factor is something that decreases the risk overall. So a risk factor would be things that increase risk, and a protective factor would be something that decreases risk. So in the family, some protective factors for people that have experienced trauma is having nurturing relationships within the family, having positive social supports, making sure their basic needs are met, so making sure they have like food, water, a place to live, finances to help them, purchase food, things like that, as well as families engaging in positive activities with each other that can like promote growth and promote healing. There's a much greater list of protective factors, but I wanted to hit on those because I think those are ones that, as people who work with refugees, it's important to make sure or encourage people to implement these if they don't already have them. So because of that tendency to like withdraw or be numb or kind of dissociate, families may have difficulty engaging with other family members or even with social supports in the community. But if we know that and we have this understanding that that's difficult for them, then we can maybe, ask them questions and find out, what's going to be helpful here? How can I help you reduce the stress so that you feel like you can go out and meet people, because that is so important to being able to heal from trauma and being able to function in the community despite what you've experienced. So some protective factors in the community would again be safe, stable housing, adequate medical and mental health services, which again becomes a whole systemic issue that I don't have a solution for. That's not the that's not what the purpose of today's webinar is, as well as engagement in community and school activities. So there's an interesting article that I read that talked about how important school is, particularly for kids who are refugees, in helping them build that sense of social support, helping them build that sense of community. And what I would venture to say is that that is likely also an important thing for the parents to be involved in as well. Like when the kids are involved in after school activities, and if the parents are able to be a part of that, that also increases their social circle. That allows them to meet, new families, new parents, to connect with people over a shared interest in their kids. And once again, that social support, that's a really big thing. If you haven't picked up on me saying that in this slide, social support is one of the biggest protective factors that we can see across traumas that people experience. And so doing what we can to encourage people to obtain that social support in ways that are feasible to them is going to be very important. I'm going to transition now into trauma-informed care. Because we have all this information about trauma and the effect it has on people, the effect it has on, the public health crisis and all this stuff. So like, what do we do? Trauma-informed care is a way of approaching it, the problem here that that can help to support the efforts of those that are trying to reduce the public mental health crisis. So what is it and why does it matter? I have this little quote here that I'll read to you. It says, a program or organization or system that is trauma-informed realizes the widespread impact of trauma and understands potential paths for recovery. It recognizes the signs and symptoms of trauma in clients, families, staff, and others involved with the system, and responds by fully integrating knowledge and trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization. So those R's that are the realizes, recognizes, responds, and resists re-traumatization, those are the 4 R's of trauma-informed care. But essentially, trauma-informed care is an approach to interacting with others that focuses on an understanding of trauma and its impact. It kind of shifts from a mindset of being like, what's wrong with you? Why are you acting weird? Why don't you want to do this? I'm telling you things that are going to help you. Why won't you do it? It shifts from that kind of a mindset into a mindset of like, you have a lot going on, and like, help me understand what's going on with you. Help me understand how I can help you, and let's collaboratively work together to find solutions that can help you toward your healing. So it's really just it's based in an understanding of the way trauma impacts people. It can be used by community resources to strengthen the prevention of trauma-related consequences, early identification of symptoms and risk factors, and trauma-specific assessment and intervention. So there are 6 principles of trauma-informed care, and they are these. The first one is safety, wherein, in a community agency, you create a physical and psychologically safe place, both for the staff within the organization and those that they serve. This is often a little bit different than what we see in, especially in big organizations that are all about outcomes and, whatever else they focus on. But if we can focus, it starts within, right? If you can focus on the safety of everybody in the agency itself, then that allows you to expand that to the people that you serve, so that when people come in and they have all this, stuff going on and they're stressed and they're scared and they don't know what's going on and they don't have an ability to like ground yet in their safety. It provides a place that in the beginning stages can help to give them that. The second principle of trauma-informed care is trustworthiness and transparency. This has to do with like organizational decisions that are made, and it's important that those be communicated with transparency, because that's what helps to build and maintain trust among the staff, which helps to create a feeling of safety, and it increases that in the clients as well. Peer support, as I mentioned, I could talk about social support, peer support all day, but it increases the trust and it promotes healing, both among staff of an agency as well as those that they're serving. The fourth one is collaboration and can't say that word, mutuality, which is partnering with individuals across all levels of the agency and decreasing the power differential. So oftentimes, you have like the big boss, the CEO, you have the people under the CEO, you have the people under those people, the people under those people, etc. And there just becomes this big power differential, whether intentionally or not, that makes it difficult to collaborate with people across all levels of the agency. What we know is that if you can decrease that power differential to a degree that is feasible within the organization, it increases people's ability to collaborate across levels, which also increases the ability to, again, build that trust, have that transparency and trustworthiness, and have peer support. So, for example, I I worked at an agency that was a residential treatment facility for children suffering from mostly trauma, but having a lot of like behavioral, social, emotional consequences of that. And the CEO, it was actually a specifically trauma-informed certified organization. And the CEO would get, you know, she would do everything. There was one time there was a kid that had, you know, very severe like behavioral outbursts, ended up having to send the kid to the hospital, but he like broke a window or a couple windows, I think. And there was glass all over the parking lot, and the CEO was out there picking up glass. And the fact that she was willing to do that, I think, set a precedent for everybody else in the agency of like, you know, any one of us can be here serving people in any capacity. And when she did it, it made it maybe seem less like menial for other people. I don't know. But that's kind of an example of what we're talking about with that power differential, that decrease of power differential, where like she was obviously the big boss. She was the one who made the decisions. She, you know, had a lot of other important things to take care of. But if she had the time and ability and capacity to help in these areas that people several levels below her probably would have otherwise taken care of, that boosts morale across the agency. And again, it increases the ability to collaborate. The fifth principle of trauma-informed care is to focus on the strength of individuals, promote recovery from trauma, and support those in self-advocacy. So again, it's less about, you know, why won't you like take advantage of the resources I'm giving you, and it's more about let's empower you to make these decisions for yourself. Let's empower you to advocate for yourself and to work toward healing in a way that is feasible for you. And then the final one is cultural, historical, and gender issues, which is about increasing awareness of cultural differences and actively working against stereotypes and biases. I'm not going to elaborate on that because I feel like that is pretty straightforward, but definitely let me know if you have any specific questions about that. Actually, I'm also going to, give me 1 second. I'm going to send a file in the chat that I used a lot in putting together like what trauma-informed care is. And there is a lot more information about there on it, but again, for the sake of time, I wanted to be mindful and just hit on main points. But there is a file that I would encourage you all to look at. There's an additional section on like how to implement trauma-informed care in an organizational setting. So give me a minute to find the chat and I will send that through. Definitely would encourage you to peruse it as, oh, the chat is turned off for the meeting. Olivia, can you fix that?
I can try.
Okay, thank you. Well, while you're trying to do that, I will go on to my next slide, which is these are the key takeaways from this, is that displacement from home and the refugee journey leave people vulnerable to a number of traumatic experiences. Again, that happens, you know, in all 3 stages of the refugee journey. Often it is a trauma that that occurs in the pre-flight stage that kind of starts the whole thing. There are a number of traumas that are experienced in the flight stage, particularly related to travel and the unknowns and, violence that can occur being in refugee camps, things like that. And then even in the resettlement process, there are a number of traumas that can occur there as well, which is why those R's of the trauma-informed care, the final one was resisting re-traumatization. And the reason that's important is because you don't want to exacerbate the problem. And a lot of resisting re-traumatization has to do with your own knowledge, your own understanding of trauma and how it impacts people. So I'd also encourage you all to continue doing what you can to learn about trauma, to learn about the impact that it has on people, because that's going to help you be more conscientious of what's going on with the refugees that come in, and it's also going to help you be more compassionate of their experiences and maybe what seems to be resistance or what have you, when really it is just that they are at capacity and they can only handle so much. There are a number of protective factors that can mitigate the impact of trauma, and again, we just named a few of them here. And a trauma-informed approach can help prevent long-term consequences of trauma. And again, that trauma-informed care can happen in community agencies, it can happen in medical centers, it can happen in residential treatment centers, like what I mentioned where I worked at one point. So it is something that can be applied across agencies, across disciplines, that can help to mitigate, once again, the consequences of that trauma. Did you get the chat activated, Olivia?
No, I'm not gonna be able to change it in meeting, but the Q&A function is working, so.
Oh, okay, perfect. All right. Well, oops. Now it's time for a Q&A. What questions do you have? How can I help you develop a better understanding of trauma?
So Dr. Denen, I'm going to go ahead and read the questions we received so far. Folks aren't able to turn their own microphones on, and we can't change that. The webinar started, but here's a few questions, and everyone feel free to keep sending them in. So this question is asking really about that moment pre-resettlement, while in that flight stage, you got a refugee camp. Is there capacity to offer some sort of care related to mental health overseas? What does this care look like if it's being offered?
That's a really good question, because this country has interesting laws about even like virtual mental health services that can be offered. So for example, if I'm licensed in the state of Pennsylvania, but I have a patient that lives in Ohio, or like I have somebody interested in services from me, but they live in Ohio and I'm not licensed in Ohio, I cannot legally provide them those services because they have to be in the state that I'm licensed in. There may be some policies in place that make that a little bit different for overseas, but again, that would also that would require people in refugee camps to have access to internet if we're looking for like virtual services, and who knows how accessible that is, who knows how often people are able to access something like internet. So I think there are a lot of systemic issues that go into that. My understanding is that there are some people who are trained in mental health who potentially, go to these countries and are able to provide in-person services there, but I don't think it's very widely established. I don't think there's that many people that do it. So that is a really good question, and I think that's something that we need to work on addressing as well, because the sooner we can implement services for people, the greater likelihood there is of us resisting, or not resisting, I guess that works, like negative outcomes. So what that looks like, I don't know. I don't know how accessible it is, but it is definitely something that we need.
Great, thanks, Dr. Denen. Here's another question. What screening tools do you recommend for mental health assessments and refugees?
Oh, that's a good question. I I know that there are some specific, do you mean like screening for mental health conditions?
Yeah, I think this person's asking like something like the PHQ-9. Is there screening tools specifically that are appropriate for the refugee population or better for the refugee population?
Well, I know that we have used the RHS 15 at meds. I am not sure of like what kind of policies they have around that, but honestly, the PHQ-9 or the GAD-7, those are, the PHQ is like a depression screener and the GAD is an anxiety screener. And I believe those are open source materials, which means that anybody can use them. You don't have to pay anything to use them. You can translate them if you need to. And those can be really good ways of just kind of like picking up and looking at, whether there's, the existence of anxiety or depression. And while those are not specific to trauma, people with trauma experience anxiety and depression. So if you administer some of those measures, it can at least give you a cue that something's going on. And then you can potentially put in a referral to mental health services. And then they can do a more thorough evaluation of like, is this trauma related? What's going on? What does this person need in terms of services? But honestly, I love the PHQ and the GAD. Like, those are both great measures. They're short, they're quick. They probably have already been translated into several languages. I just haven't looked at that specifically. But I would definitely recommend starting with those because they're easy and quick and accessible.
Thanks, Dr. Denen. Here's a question that I really like, especially as the CEO of a health center. I think giving our providers more tools for their tool belt is always helpful. So this question asker asks, therapy is so key to helping people recover from trauma, but where I work, there's almost zero access to trauma-based therapy, especially for our non-English speakers. As a physician, what can I recommend or offer people to help heal?
That is a very good question. Again, I feel like this is one of those systemic issues that, hopefully your organization would be able to address in some way. But there are interpretation services that can be accessed. Olivia would be able to speak more of like how that happens, because that's not my area. But one of the advantages of COVID is that it has significantly increased the accessibility of like virtual therapy services. Again, that requires people to have access to internet. It requires them to have technology. So there are a lot of things in place there that would have to be, accessed in some way. But I think that is a good starting point. If you don't have resources in the community, or if you're not sure where to start, is to maybe do some research yourself on provide. Again, they would have to be in the state that the person lives in, but providers that provide virtual services, and then work with the individual to find out, like, would you be comfortable, like if you have a family member that, speaks English or something like that, would you be comfortable with having that family member interpret? Otherwise, how can we help you access an interpreter so that you can get these services? I mentioned the thing about a family member interpreting, but most of the time we try to stay away from that because it just blurs the lines a little bit too much. Like, there are certain, like, I love my family. I'm pretty close with my family. But there are certain things that I would not want to talk to with a therapist and have a family member over here. And I'm sure that's the case for many of you. So it's kind of like at a last ditch effort, you can do that, but definitely it's important to, do your research and see if there's a way to access an interpreter that can aid in providing those services.
This is an interesting question. I like this a lot. I think this comes up a lot for the folks on the call who who are trying to provide the best aid they can for their clients. So for many cultures, the discussion of mental health concerns is taboo. How can we best navigate this for individuals to get the support and help they need?
Honestly, I think that whole trauma-informed approach is one of the things that can help with that. It's not going to fix it immediately because it is so ingrained in people that like mental health in general and mental health services are something you don't talk about. They're something that you don't engage in. You just pretend that it's not there. So the trauma-informed approach is not going to fix that, unfortunately. But I think the more that you build relationships with people, the more that you create a safe space, especially if you're somebody who has, repeated communication with these refugees, you'll start to build relationships with them. And in doing that, you will be able to form this like sense of trust potentially. And then maybe later down the line, they'll be more open to it. Some of that is also just going to come from acculturation as they, become more familiar with this culture, because mental health, I mean, it's taboo in this culture as well, but not nearly as taboo as it is in, some of the cultures that our refugees come from. So there's not an easy answer, but, having an understanding of what's going on builds a sense of safety and trustworthiness. And that's kind of where you have to start. Unfortunately, we can't force people to do something that they don't want to do. And because of the effects of trauma, people might be very resistant to things like that, especially when they first arrive. But continuing to invest, continuing to provide the support as it's there, and doing what you can in whatever capacity, whatever your relationship is with this person, to encourage growth, hopefully down the line will make them more open to it. But it is not an easy thing to solve, and it's definitely not going to be solved overnight.
Thanks, Dr. Denen. I think this question is interesting because it looks at the other end of the spectrum. So we have clients who maybe are not yet ready to approach mental health therapy or to make that final step. But we also have providers who don't have that rich education around trauma-informed care. So for providers who want to learn more about providing trauma-informed care, maybe to improve the services they are able to offer to refugees, where are some places that you would suggest that providers seek materials, educational opportunities to become more informed?
So trauma-informed care is like a big thing these days. So honestly, if you Googled like trauma-informed care training, you would probably find a lot of resources. I know the organization that I worked with that was a specific like trauma-informed agency, it was certified through something called Sanctuary. And I don't know what the process was for getting the Sanctuary certification, but you could also like search for like Sanctuary trauma-informed care, and it would bring you to what that is. And it's an agency-wide, like there are several agencies across the country that are specifically Sanctuary certified, which is a trauma-informed approach to care. So that may be something worth looking into. Honestly, there are lots of TED Talks. I love TED Talks because they're like not that long, they're super informative, and they're just really accessible. There are tons of TED Talks on what trauma-informed care is, and I think the more you absorb that kind of information, the more it's going to become part of the way that you think. So in terms of like agency certifications, the only one that I know specifically is Sanctuary, but the Substance Abuse Mental Health Services Administration, that's actually what I was going to try to send you guys was in the chat, was this document that they had kind of introducing trauma, like what trauma is, what trauma-informed care is, and how to implement that in an agency setting. So they have like helpful information. But honestly, like I said, I would start Googling, because a lot of the like national mental health agencies have a lot of valuable information about that. And if you're interested in an agency-wide certification, I would look into Sanctuary.
Thanks. All right. We have a few more questions in the Q&A. Dr. Denen, thank you for answering all these questions, and thank you to all of you for submitting them. In refugee resettlement, frontline staff also find themselves sometimes needing to be practical and to manage personal boundaries, not overextending themselves with individuals who are depressed and struggle with motivation. How can frontline staff strike the right balance of being sensitive to trauma while also maintaining reasonable client expectations and personal boundaries?
That is a great question. And this is just going to be like a cliche answer, but really self-care. Self-care is so important for anybody that does any kind of frontline work. You have to be able to have those boundaries. You have to be able to say no. Because people are going to inevitably ask you to do things that you can't do, whether because you have, you know, a family thing that you have to attend to, whether you are just at capacity and you can't do it. And you have to be willing to say that, which I think comes with, for those of us that enjoy, you know, serving other people and helping other people, that's a hard thing to learn. Because we want to be able to sacrifice, we want to be able to do these things that people are asking for because we genuinely care about these individuals and we want them to grow and develop and find healing. But ultimately, you have to remember that that person's growth and healing is not up to you. You are not responsible for that. You are responsible for your own wellness, and the wellness of your family or your community or, you know, whatever you have going on in your life. And so I think, again, it comes with a lot of self-reflection, and a lot of considering what you need. Like if your tank is filled, or I'm sorry, if your tank is empty, what do you need to fill your own tank? And what do you do when somebody asks you for help and you just can't do it? And a lot of times what helps in those situations is to have like resources on hand that you can provide people, or even to say, you know, like, hey, I really do want to help you, but right now I'm not available to do so. So let's rain check, you know, or, you know, here's somebody that you may be able to contact, or, you know, I'll get back to you, or, you know, something like that. Just being clear about what your boundaries are and that it's not that you don't care. It's just that you can't do everything. Because if you try to do everything, you will collapse and you will be of no help to anybody. So it's kind of like, you know, the whole oxygen mask on an airplane thing where they tell you like put the mask on yourself before helping somebody else. Because if you're trying to help everybody else first, you're going to pass out because you're not going to have any oxygen. So it's the same kind of idea where if you are not in a place like physically, emotionally, spiritually, what have you, to provide services to people, you have to take care of yourself first. And I know that that's a cliche thing to say, and I know that that's not an easy place to get to mentally when you just want to help people, but I would say that's kind of where you got to start, is create some kind of a self-care plan of this is what I'm going to do when I feel at capacity. These are ways that I can communicate my boundaries to other people in a way that doesn't, you know, feel like I don't care about them or whatever. And that being said, people are going to interpret what you say how they're going to interpret it. So you also can't control that. But hopefully people will be, you know, understanding and you know, hear what you say for what you say, that like you want to be able to help them. You just can't right now. That's what I would say about that.
Thank you. I think we have time for one more question. So this question is asking, you mentioned peer support as a protective factor for our clients, but are there ways you think that peer support can help providers? Is hosting a group, is hosting a group within an agency something that has been explored at other agencies? And Dr. Denen, before I pass this over to you, I will also share, I know one of the local language access firms in town actually hosts a group for their interpreters, because interpreting for mental health appointments can be very difficult. And that is a source of comfort for the interpreter to have a chance to connect with their peers on the difficulty of the work that they do. And then Dr. Denen, do you have other examples of peer support groups, or do you think that could be helpful?
Absolutely. Like I said, I love peer support, social support, whatever. Like that's a protective factor against everything. You know, if you are just experiencing a bout of depression, if you've had stressors go on in your life and you're really anxious, like, you know, sometimes we have the tendency to withdraw and want to be on our own. And sometimes we do need the time and space for that. But having some kind of social support is one of the biggest protective factors for anything. So I don't know of any specific groups offhand. I mean, it would also depend on the population or like what it is that you do and what kind of peer support you're looking for. But I would definitely encourage you to find that. You know, even some social media sites will have like groups. I mean, obviously you have to be careful because sometimes there's toxic people in those kinds of groups. But for example, if you are a physician and you're feeling burnt out, it may be helpful to talk with the other physicians in your agency about feeling burnt out and kind of develop some community there. And again, that's part of a trauma-informed care approach, is to be able to have that sense of community and vulnerability, so that everybody gets supported in the way that they need it, where there's not judgment, even if the other physician isn't experiencing the same thing. They have an understanding probably of what it feels like to be burnt out, and they are, you know, they're willing to listen. So I would just encourage you, like, whatever you feel like you need, that's an important part of self-care as well, is to have that, you know, community support. How you go about finding that, I don't know exactly, other than social media, but, you know, you may be able to also Google it and be like, you know, peer support group for physicians, or, you know, whatever, and who knows what you'll find. But I definitely would encourage you to reach out to those in your community that you do know, whether they work specifically in your field or not. You know, because, for example, if you're a physician, that doesn't mean that you can only talk to physicians about burnout. You know, everybody has probably experienced burnout at some point and has the ability to sympathize with that. And just being able to talk about it and vent, and, you know, if you need solutions, having that person help you brainstorm solutions, or if you just need to kind of get it off your chest, that can be really helpful as well.
Thank you so much. We are exactly on the hour and we are out of time for today. Thank you again, Dr. Denen. That was wonderful. And thank you to you all for joining us. The recording will be shared with all who registered, and we hope to have the opportunity to have something like this again in the future.